Okay, this video is your 2020 CPT modifier video. Probably won't be too long. What I want to cover is refreshing again what your resources are and where you can get your definitions, and then get into the textbook some so that you can see the table with all the explanations, and then we'll end with 5 or 10 examples of or scenarios that we'll find modifiers for. So again, the front cover of your CPT manual will have modifiers, all different kinds, your provider types, your hospital outpatient types, your HCPC types. This is a great, once you're familiar using modifiers, this is a great shortcut, cheat, great place to put notes. If you want complete definitions of your modifiers, and this is a good place to study them, then in Appendix A, it has the explanations, different notes, like the very first one, 22, increased procedural services, explains what it is, and then it has a note, this modifier should not be appended to an E&M service. So this would be good. You could come over here and write a cheat right here on 22. Oops, sorry for the glare. On 22 and put not with E&M or no E&M. That's how I would do that. And then you won't ever have to necessarily know that again or memorize it. It'll be right there as a good reference, which is what I call cheats. Okay, so now let me show you in your textbook. And actually, I think I'm going to do this because when we do our little practice drills, I'm going to have this where I can get to it. Okay, so in our 321 Coded, I'm in the 2020 321 Coded textbook. And remember, if you are planning on going through this course, you don't have your textbook yet, get it, because we're going to be very heavy in it. It's a great textbook to have, great for reference even after you start working. And this course, you won't be able to pass without it. Okay, so if you're on page 344, this is in your chapter 9, Intro to CPT. They bury your modifiers in here. And they have a wonderful you have a table that kind of has a synopsis of a lot of them, not all of them, but a lot of them. These are your CPT modifiers, not your HCPCs. When we get into HCPCs, we'll talk more about those modifiers. But these are geared toward the CPT. And what this textbook previous, if you're reading the wordy stuff, it's going to talk about 2 different kinds of modifiers. And that kind of, if you get your mind around why they're used or how they're used, it kind of helps you use them, apply them. So there's 2 different ways to think about modifiers. One is a modifier that affects reimbursement. So if you use that modifier, it could potentially increase reimbursement, cut reimbursement, divide reimbursement among people, providers. And then the second is just informational only. So as we're going through this and we're talking about them, I'm going to hopefully explain that usage better. But if that's key, if you can break them down into, okay, I don't know how to use this modifier. So ask yourself, could this modifier do something with money? Or is this modifier just giving me information, like the left side, something like that? Okay? So how this table divides them up, and what, as you study through the book, what I would recommend you do is, just like I showed you on that modifier 22, write notes in this front cover. As you, I need to know that, write that note on this front cover of these, all the modifiers, and then you can keep you study it once, and then you've made yourself a handy reference. So you will find, and I know if you don't have this book, it's going to be very hard for you to read the words, and I know that I don't have my own studio to do this in to make it, zoomed in as wonderful as what I would like. So this table divides it into different sections. So I'll say out loud, so if you don't have the textbook yet, at least you can take notes for what I'm saying. So a special evaluation or E&M case modifiers would be modifier 24, 25, and 57. And what that means is these would be modifiers that would go on an E&M code, would not go on a procedure code. So if you're in the 11,000 series of your CPT, that's an action code, a procedure code. These would not go on it. These are only going to go on those 90,000 codes that are in your E&M section. So your 24, and I probably will not read every single one of these, but just to kind of give you an idea in each section. Your 24 modifier is an unrelated E&M service by the same doctor during a post-op period. So what that means is patients in their post-op period for bunion, and they've had their surgery on that bunion, they're going back to the same doctor, and now their thumb hurts. So they're going to have an E&M regarding this thumb, maybe they have arthritis in it, during the post-op global period of their bunion surgery. So this would flag that E&M code that, hey, yeah, we know that this patient is in a post-op period. We know that they shouldn't get an E&M. It should be included in a post-op, but this is for a completely different problem. Okay? 25 modifier. This is a significant separate. So how this could work is you show up for your annual wellness visit or your annual exam. And this is the scenario where you have, oh, and by the way, I've had a really sore throat. Or, oh, and by the way, my back really hurts. So you're going to use a preventive code in the E&M section for the annual visit. And then you're going to use what we call a sick code, an established patient code for your, quote, sick visit. And then you'll put the 25 modifier on that sick visit. You made the appointment to show up for the preventive visit, so that gets paid. That's first. That's the reason that the appointment was made. And then the, oh, by the way, I'm sick, gets your 99212 or 99213 or whatever it is with the 25 modifier. And there are great examples in here. I hate people reading what's sitting there, so I won't do those. Your 57 modifier is a decision for surgery. And that one's pretty self-explanatory. If you're at the docs and you decide to have surgery, then they're going to pin that 57 modifier on it. Okay, the next section will be your greater, reduced, or discontinued services. So these are any services that you have one cost and it's going to cost more because you had to do more. Or you have one cost and you didn't get to do as much as you thought you would get to do. It has a cost, but you had to discontinue the procedure. That kind of thing. That's what all of these are with good. Oh, there's 74 as well. So it's 22, 52, 53, 73, and 74 all fall under that. It's going to be greater, which is increased cost, reduced, less cost, or discontinued, which would probably be a lower cost, maybe, depends on. Okay, so far, everything here affects money. If we have an extra E&M with an existing E&M, that costs money. That's extra money. So that would be one of those functional or money related, reimbursement related modifiers. If you're reducing services or increasing services, that reimbursement, that affects money too. So far we're not to any informational kinds. Okay, global surgery. Under the global surgery section, and this book really does have some excellent ways, decision trees, that kind of thing, to think through things. You're going to have your 54 for surgical care only. So that surgeon only did the surgery part. They didn't do the pre-op, the post-op, any follow-up, nothing. They only provided the surgery. 55 is post-operative management. So another surgeon provided the surgery, and this doctor's only providing that post-op part. And then you have 56 pre-op only. So again, that's just flip-flop. This doctor would have only provided the pre-op management of that surgery. Okay, then we're into special surgical and procedural events. Again, still money related, still reimbursement related. If these modifiers go on a code, it affects how that code gets reimbursed. So 58 is a staged. 59 is the most heavily used modifier there is, except for 51 probably. Distinct procedural service. When this first came out, we put it on just about everything because if you get it through NCCI edits. Does it so much anymore? Maybe, maybe not. I do think we're getting better as an industry and as coders to apply our modifiers better. So your 58 staged, this is woman has breast cancer, goes in and has a mastectomy. She knows that she's going to have reconstructive surgery coming up. So that reconstructive surgery could be construed as staged. She's going to have her cancer removed and have reconstruction as a big procedure in staged segments. So that's what a 58 modifier would be. 59, and then you have your XE, XS, XP, and XU. These are CMS. CMS had to get their little funky modifiers stuck in there. Haven't been around for too awful long, but this helps. This is some of the same ideas, but CMS just has it flagged with different symbols or different letters instead of numbers. 63, this is specific just to infants, so you might want to kind of flag that one. 78, unplanned return to the operating room following initial procedure. This is with the same doc. So unplanned return to the op room, same doctor, following initial procedure for a related procedure during post-op period. So there's a lot of different phases to that. 79, unrelated surgery by the same doc during the post-op period. So where we're different here, one is unplanned. So this could be a bleeding issue or a complication issue. Unrelated during post-op is surgery on a bunion, and then you fall and break your hip during your post-op or during your global of the bunion. So now you've got completely different procedure that has to be done, completely unrelated to the bunion. Something like that. Okay, so now we're getting into bilateral and multiple procedures. Keep in mind, we're still reimbursement. Nothing here is informational only. All of this is affecting money some way or how it gets divided. Bilateral, 27, multiple outpatient hospital E&M encounters on the same date. That's very specific to outpatient hospital setting only. So make sure you don't get this confused with the 25, which is your physician-based. 50 is bilateral. So if something is done on both thumbs, there's a mirror image of thumbs, or mirror image of eyes, mirror image of ears. Anything that is considered bilateral, then you would use that. 51, is multiple procedures. This is when multiple procedures are done, and there's very specific how you can use this. Multiple related surgical procedures performed at the same time. Surgical procedures that are performed in combination, whether through the same or another incision, or that involve the same or different anatomy. Combination of medical surgical procedures performed at the same session. Okay, and they give great example. An example of multiple procedures: patient underwent a right tibial shaft fracture repair and an arthrodesis of the left knee. So tibial shaft, the right tibial shaft is on the right leg. The arthrodesis is on the left knee, but they did it at the same session so that would be considered a 51 modifier. 2 procedures, same anesthesia, same operating room. Okay, repeat services. Again, we're down to money. We're still in the money. 76 is a repeat procedure. 77, repeat procedure by another doc. 76 is the same doc. 77 is another doc. See, these aren't too bad. If you kind of read them out and highlight the differences, makes it not so bad. Multiple surgeons. Again, we're still talking about reimbursement. It changes how the money is split or who the money goes to. So 62 is 2 surgeons. That would be very pertinent if you had to have 2 surgeons working on a patient. 66 is a surgical team. 80 is an assistant surgeon, different than than 2 full surgeons. 2 full surgeons, it took 2 full surgeons to perform the surgery. An assistant means that someone assisted the main surgeon. We have a minimal assist surgeon, and then we have assistant surgeon when qualified resident surgeon isn't available. Okay, preventive services, this is modifier 33. A lot of times or most of the time, this is put on the preventive visits if maybe the insurance company required that it be done. If it's a requirement of a third-party payer, 33 will be appended to it. Again, still reimbursing. These are not informational yet. This is all for reimbursement, cutting up the money. 26 is the professional component. This is used on your radiology code, most of your radiology codes, a few medicine codes. This is that x-ray that the doctor orders. You go, or the patient goes to the hospital to get the chest x-ray done, maybe before pre-op. Maybe it has to be done pre-op. So you go to the hospital to get the x-ray done. So the hospital owns the x-ray machine and the technologist who takes your x-ray. They may or may not own the radiologist who reads the x-ray. So the doctor who reads the x-ray, renders the report, gets a 26 modifier. The hospital gets a TC modifier, technical component. They're both considered components. So there's a technical side and a professional side. And we'll talk more about this when we do radiology, but that's what that is. Mandated services. These go somewhat with your modifier 33. Where did 33 go? Have I already lost my mind? Maybe. Oh, hello. 33. Let me go back, because your 33 alerts the third-party payers regarding the preventive visit. 32 is that mandated. I am sorry. I got my numbers mixed up. Your 32 is your mandated, so that service may very well have been required by your insurance company, an attorney, something like that. Your 33 still goes on your preventive visits, but it's just going to alert your third parties. I'm sorry for that confusion on that. Let me, since I got ahead of myself, let me give you an example of this 33, and then I'll give you an example of the 32. And again, I apologize. Long day, I guess. Okay, so patient goes to their primary care, has a 20-minute counseling session or something for smoking cessation, something like that, or to quit using dip, some tobacco cessation, something like that. Then this 33 is going to be put on that counseling session that's going to alert the third party payer that under the preventive applicable laws, there's a cost sharing that's going to go on with that because of that additional counseling that was done. Your 32 for mandated, patient goes to their primary care. The primary care recommends a respiratory therapist. The payer requires, so their insurance requires that the patient undergo a level 3 E&M before they can see that respiratory therapist. So they put a 32 modifier on that E&M service before they saw the respiratory therapist. Okay. Okay, moving on to unusual anesthesia. Actually, that would probably go on the actual, that would be the consult. So the respiratory therapy is what was mandated, so that's the service that it would go on, not the E&M from the PCP. Unusual anesthesia. 23 modifier, unusual anesthesia. So maybe you have someone with some developmental disabilities, they don't do well, or they don't quite understand when they have to encounter some healthcare procedures. So it's better to use some anesthesia to limit their stress in the situation, that kind of thing. So that would be, and you would probably need some diagnosis codes to prove that and back that up, which you would have. Anesthesia by the surgeon, that would be unusual. And so that would have to be flagged that way. Your lab services, your 90 is a reference to an outside lab. 91 is your CLIA. And then 92 is alternative lab platform testing. Kind of flags if you're, where you're getting the labs, are they accredited or not, and different platforms if you have to go to an alternative. And then 99 is just if you have a whole lot of modifiers, then this 99 is used to alert the third party payer that, or your insurance, whoever that third party is, that there's more than 4 modifiers that have been used. Okay, so we still have a few more. Your telemedicine, this is kind of new. Telemedicine's new. That's your 95 modifier. So that's going to go on the telemedicine service code to flag and let them know. Say patient underwent psychiatric diagnostic evaluation with medical services, whatever that code is, 907 something, this 95 modifier would go on it to help flag what service was done. Telemed. 96, this is some of your rehab. So you've got 96 and 97. One is for patients learning skills and functioning for daily living, different daily living habits. 97 is for your rehab. So it's patient to keep and learn and improve skills of their daily living. Generally, your rehab, you may be relearning because maybe you've had a stroke, so you would be relearning. Whereas 96 could very well be a 3 or 4 year old that maybe has some speech issues. They haven't ever learned how to speak. So they're learning those habits from the beginning. Okay, so rehab would be more of a relearning. Okay, so let's look at a couple of examples. And I have this open so I can kind of look, because this is exactly how I would do it in the real world. So let's take an example. Assistant surgeon reporting patient's cesarean section, delivery only. So this is an assistant surgeon reporting patient's C-section, delivery only. So what I would do is I would come here, look down the modifiers, would already have some of my notes put in here. The key part here is assistant surgeon. Doesn't necessarily matter what the surgery is. So I would come down to assistant surgeon and I would put an 80 modifier on that CPT code. Let's do another one. Treatment for chronic conditions at same time of preventive medicine visit. So we have treatment. So we have two things going on. Patient showed up for a preventive visit, and the doctor also covered all of the chronic conditions. So they may have refilled blood pressure meds, refilled diabetes meds, all of that kind of stuff. So that would be a 25 modifier. Remember, you would list your preventive visit first. That's why they made the appointment. And then you would have a second E&M service, and you would put the 25 modifier on that second service, signifying that it is significant and separate from that preventive visit. Okay, let's do post-operative management of a vaginal hysterectomy. Post-op management of a vaginal hysterectomy. So based on that information, we do not know that provider did anything pre-op or operative. This is only post-op. Post-op. So I would look down through here. And it takes me a minute. So 55, post-operative management only. That's the modifier you would put on the E&M. Or on the CPT code. Okay, let's do one more. Needle core biopsy of the right and left breast. Needle core biopsy of the right and left breast. So when we think about that, the 50 modifier is bilateral. Bilateral means anything that we have a mirror image for. Mirror image. So that I would put a 50 modifier on that CPT code for the bilateral biopsies. Okay, let's do a consultation required by payer, just because I mixed up what I was saying earlier. So this is a mandated service. The consultation is required by the insurance company. So that's going to be a mandated service, which is 32. 32 mandated. Insurance, attorney, courts, somebody mandates. They're making you go to it. All right. Let's do, if you're in your 321 coded, I want to do, nope, let's do one more from where I'm at. We won't do that. Sorry. I get on these real time and then I get excited about stuff because I just love to code. So, okay, let's do another one. Actually, let's talk a little bit about, because we haven't talked about we've talked all about the reimbursement kind. And remember, reimbursement affects the money. We have not talked about the informational ones. So let's look over here under our level 2 HCPCS and let's just read these. LT, left side. So that's just information telling us what side of the body. E1 is telling us upper left eyelid. So your E1 through E4 has to do with your entropion and your extropion surgeries. and others, but those are the very common ones. When your eyelids either fold inwards or they fold out. Your F, A through F9, I think of F as finger. So these are all your fingers. Left hand, second digit, left hand, third digit, fourth, fifth digit, your thumbs. Then let's go down to the bottom, TA through T9, T for toes, F for fingers, T for toes. That's how I remember them. I'm sure that's how they put it together, but that's how I remember it. So if there's specifically something with fingernails, with joints of the finger, these would be modifiers that you would use. And then in between here we have GG. This is performance and payment of a screening mammogram and diagnostic mammogram on the same patient on the same day. LC, left circumflex coronary artery. LD, left anterior descending coronary artery. The reason we would use these is if they were putting stents in them. They would be very good for stents, angioplasties, that kind of thing, to keep track. So you can see how these informational modifiers very much differ from how the money is split. That's probably all I have for you for the modifiers. As we go through the different organ systems within the CPT, and we do these little practice scenarios, we'll be using modifiers along the way. That we use a lot. Seems like we use a lot of 51s and 59s in integumentary, and that's coming up in a few videos. So this is just kind of to get our feet wet, and then hopefully along the way we'll gain more knowledge and more comfort level on how to use them. So that's it on modifiers, and I'll see you next video.